Hello friends, once again welcome to Medscope with Benson. Remember, this is part of our clinical medicine series of videos. If you guys love these videos, they help you learn, you benefit from them. Please help us, and you can do so by subscribing, hitting your like buttons, sharing these videos, and so forth, so on. Without further ado, let's dive into diagnostic approaches to hypertension. So a patient walks into your office. You do want to obtain blood pressure readings from both of their arms. Why we insist so is you do not want to miss issues like aortic diseases and the subclavian stenosis. Now, are the blood pressure readings hypertensive? Okay, if so, or elevated, that is. If so, you do want to book them a return to office in 1 to 4 weeks. But the earlier the better though. Now, once they get back to the office once again, please get the readings from both arms, okay? We insist on this because we at least want to get two or more readings in spaced, okay? In 2 office visits, for example. Are the blood pressures elevated again? If yes, then you do want to rule out what is called white coat hypertension, because some of these patients get nervous when they come to your office. You do want to do what's called a 24-hour blood pressure ambulatory monitoring, and that can be done from home. Now, if they are normal, then that confirms that that is white coat hypertension. Are the blood pressure readings greater than a systolic of 180 and a diastolic of 120? Yes, if that is hypertensive crisis. But are they negative for target organ damages? That is hypertensive urgency. Is it positive for target organ damage? That is hypertensive emergency. Friends, we want to look into treatment guidelines for chronic hypertension. That is the bread and butter of hypertension. Now, we do have the stage systolic blood pressure readings, diastolic blood pressure readings, and the treatment. So, the blood pressure is systolic of 120 and a diastolic blood pressure reading of less than 80. My friends, that is normal, but at any given stage, you do want to insist on lifestyle modifications. That is, reduce the weight. Use of the DASH diet, very, very useful, okay? Exercises, okay? Reduce the sodium diet, reduce the alcohol. Now, same thing for prehypertensive patients. That is, systolic blood pressure reading of less than 130 and the diastolic blood pressure readings of less than 80. We advocate for the same lifestyle modifications. For stage 1, my friends, that is a systolic blood pressure reading of 100, less than 140, and less than 90 for diastolic blood pressure readings. You do want to apply the lifestyle modifications as above. That is, reduce your weight, okay? DASH diet, that is very, very useful. Exercises, reduce the sodium diet, okay? Reduce alcohol. But if these patients have atherosclerotic cardiovascular risks of greater than or equal to 10%, that means they have issues, other issues, for example, that you'd have them start on these antihypertensives, my friends. Maybe they have an MI or a stroke, okay, of risks of peripheral artery diseases. You do want to start them on ACEs, that is the angiotensin converting enzyme inhibitors, ARBs, thiazides, and calcium channel blockers, that is the CCBs. Okay. At stage 2, my friends, that is blood pressure readings systolic of greater than 140 and a diastolic of greater than 90. You do want to start them on antihypertensives. Yes, you want to push for the lifestyle modifications, but my friends, even if they do not have the atherosclerotic cardiovascular risks of greater than or equal to 10%, start them on antihypertensives. And your choice is ACEs, ARBs, thiazides, and calcium channel blockers. Sometimes in your exams, okay, They can even choose. They can choose to ask you on which ones to know when to use. Okay. Now, in African American, calcium channel blockers and thiazides, that's me and you, work better than the ACEs and IRBs. The reason why they say so is because we black, the African Americans, have what is termed as low renin hypertension. Now, again, how do you choose these antihypertensives based on the comorbidities, for example, my friends? Now, things like post myocardial infarction, all right? Beta blockers work better for you, my friends. That is metoprolol and vedolol, okay? ACEs also, ACEs and ARBs also work better. They reduce ventricular remodeling at that point in time, my friends. Number two, heart failure. You want to make choices just as above. That is the beta blockers, your ACEs, your ARBs, okay? But you do want to add them on aldosterone antagonist, that is spironolactone also. On coronary artery disease, okay? Same as above, that is your beta blockers especially, all right? But you do want to add them on calcium channel blockers. That is diltiazem, verapamil, or amlodipine. They work better for you because again, they have benefits that have been studied and good for your patients, my friends. You do want also to put them. You can consider your nitrates. That is isosorbide dinitrate or isosorbide mononitrate. Okay, they are beneficial at that point in time because especially if these patients have angina, okay, they reduce the contractility, their myocardial oxygen demand, okay, and that actually helps or is beneficial for your patients. For AFibs, atrial fibrillations, you do want to consider your beta blockers, metoprolol, calvedolol. For another aspect that you can add on your AFibs is then dihydropyrimidines, okay? The calcium channel blockers, that is your diltiazem verapamil, all right? Because those ones, to some extent, are very beneficial for those patients that have AFib. For diabetes and chronic kidney disease, my friends, you employ your ACEs, institute them on your ACEs or ARBs, lisinopril for ACEs, losartan for your ARBs. Very, very important, my friends, because that has been shown to reduce proteinuria. They have also renal protection and at the same time also reduce what is termed as albuminuria. For your pregnant patients, my friend, that is very, very important. These drugs, I want you to remember, are mnemonic by Health Mothers Love Nifedipine. So if for your H, that is hydralazine, for your M, that is methyl dopa, for your L, that is labetalol, and your N, that is nifedipine. These are drugs that have been shown not to have, they are non-teratogenic. They don't have the teratogenic effects for your developing fetus. In osteoporosis, my friends, you don't want to consider HCTZ, that is hydrochlorothiazide, okay? Now, those ones conserve calcium, right? Now, in BPH, my friends, you want to consider the alpha 1 receptor antagonists, tamsulosin, doxazothins, all right? That's very, very crucial, my friends. Now, what are some of the things, contraindications? We're going to do that more in our pharmacology videos, but you do want not to consider beta blockers, okay, in hyperactive airway diseases like COPD, asthma, all right, or acute decompensated heart failure. Now, another aspect is you do not want to use calcium channel blockers in acute decompensated heart failure. Please also avoid your ACEs and ARBs and aldosterone antagonists, especially in patients who have AKI, because that is likely to cause what is called hyperkalemia. Now, you also want to not to utilize the thiazides in gout because that increases hyperuricemia. That causes hyperuricemia. Now, my friends, you've confirmed that these patients have this crisis right here. There is a blood pressure reading that is systolic of 180 and a diastolic of 120, that is greater than those numbers right there. Maybe they're showing signs of neurological deficits, any encephalopathy, confusions, my friend, chest pains, signs of EKG changes, my friends. You know, aortic, heart diseases, right? They have heart failures, AKI. You do want to confirm that. That is signs of target organ damage. If there are, for example, the CVAs, the acute, the ACIs, the heart failures, aortic dissections, AKIs, if there is, that's either yes, my friends, that is hypertensive emergency. All right. Now, you need to drop your map by about 25% in fast to 2 hours, 1 to 2 hours, and please use your IV agents. All right. And you do want to reduce these blood pressures further to less than or equal to 160 systolic and 120 diastolic in about 2 to 6 hours. If there was no, and again, you need to now further normalize the blood pressure readings in 1 to 2 days. If there was no signs of thought, that is hypertensive emergency with the same blood pressure readings, my friends. So aim to reduce the blood pressures to less than or equal to 160 systolic, 120 diastolic in hours. In this, there is no need to rush to your IV agents. Please use your oral meds. Intend to normalize your blood pressure readings in 1 to 2 days. You do not want to reduce these blood pressure readings abruptly, because there are complications that come with abrupt reduction of your blood pressures. That is likely to worsen, that causes ischemia. It's likely to decrease perfusion and worsening your organ malfunctions again. All right. Now, what are some of the choices of the IV antihypertensives that you'd want to use? This one is based upon availability. All right. But again, whether you are likely to use what's called infusion, that titratable, or those ones that you can do IV pushes. Most common ones in our settings is actually hydralazine and labetalol. But there are also other IV agents, that is nicardipine, esmolol, and nitroprusside. But we do want to be very, very careful with nitroprusside, because that is likely to cause or worsen what is termed as lactic acidosis. My friends, up to that point in time, we come to the end of your hypertensive playlist. Until then, see you again. And thank you so very much for subscribing.